we know the research is clear that the most common cause for recurrent miscarriage is
there's OBGYNs that know about hormones and how to prescribe them. But if they're just simply regularly bringing babies and that's it, they know no different. They have not been taught.
That's interesting.
Dr. Hilary Howell, founder of Apothecary Company, has been in the pharmacy business over 20 years and has practiced as a pharmacist for 17 years.
She is a certified nutritionist consultant and is pursuing the pathway to the Institute of Functional Medicine Practitioner Certification Program.
What do you see as some of the red flag root causes?
The biggest key player is,
I'll let you take it away.
Why would someone be on birth control? Here's your birth control at 16 and for whatever reason, and then when you're ready to get pregnant,
these women are not given realistic expectations. Birth control is the most.
It was just a pill for the ill, a collection of just no one getting better.
What do you think? Do you know?
This is just going to be an ongoing issue. I don't see it getting better.
Genetics load the gun, environment pulls the trigger.
No one's going to save you but yourself.
Welcome to Prescribing the Truth. I'm Dr. Nichole Morris, a Catholic naturopathic doctor and natural fertility expert. Around here, we don't just accept the mainstream narrative, we question it. My goal with every episode is to share the love of Jesus with you and empower you to make informed, confident decisions for you and your family. So grab a cup of tea, get comfy, maybe even throw on your tin hat, and let's dive in. Welcome to Prescribing the Truth. I am absolutely thrilled to be here with you today. I cannot believe today is the day. After years of dreaming up this podcast, here we are. And there is no better guest for me to have today on our first episode than my friend, my colleague, and Dr. Hilary Howell, functional pharmacist. Welcome. Super glad to have you here with me today.
Thank you. Thanks for having me. Congratulations on this whole endeavor.
Thank you. I've been mulling it over for a few years, and it was time to rip the Band-Aid off and let the world hear what we have to say, I suppose you could say. So I'm excited to start with you. I think it's just like the most ideal first guest to have on the podcast is you. So I love to just like kind of share with the world a little bit about how we came to know each other and what that looks like, and then kind of dive into your story. And we're going to spend some time today talking about different pharmaceuticals used in the fertility world, a little bit about birth control, some nutrient deficiencies, things like that. Dive into the nitty gritty and share with you all. So do you remember how we met, Hilary?
You randomly called me. I'm like, who's this? And I was pretty new in my business adventures. And then,
Yeah, exactly. I remember I had a client come in and they were like, there's a pharmacist in Oxford and you should probably know her. I don't think you were open yet. And I found your phone number somehow and I kind of stalked you, and the rest is history. I think, what month did you open? June or July, right?
Yeah.
Yeah, it was a few months before that. And Hilary has been so gracious to me over all of the years. Some of my early days saw clients in her office or in the pharmacy there, and here we are. So let's dive in. If you feel up for it, I'd love for you to share a little bit about your story and how you came from conventional pharmacy into this more holistic world of pharmacy.
Sure. So I have been a pharmacist for over 20 years. I did a lot of, obviously, retail pharmacy. Managed a pharmacy for 10 years. And then all of a sudden, after having 2 kids, my husband was diagnosed with a rare form of cancer, so leiomyosarcoma of the prostate. So at that time, having the education that I did or do, I was digging through all this literature to see what I can do from a natural side, because having cancer in itself the odds are not very high, right?
Right.
So when you're faced with that type of reality, you go to the conventional side of things and it's chemo, radiation, and it did not sit well with us. At that point, we didn't have good odds even doing that. So it kind of opened my eyes to this whole functional medicine realm. So then we saw a functional medicine provider, and then I'm thinking, I'm going to go back to, James ended up passing away after 18 months, just because his type of cancer was so intense. But I didn't want to go back to retail pharmacy. What purpose was it? It was just a pill for the ill, right? And polypharmacy and just a collection of just no one getting better. So I always wanted to open my own pharmacy. So I'm like, perfect time to do it. Set up shop in a area that I had no home base in, right? I just open a new business. This was 6 months before the pandemic.
Yeah.
And I just did my thing. So we opened a cash-only pharmacy, so no insurance. There's a time for medications, obviously. So I wanted to be able to provide that without any red tape. I do compounding pharmacy. So we do pet prescriptions, and we do a huge amount of bioidentical hormones. And we have a great herb wall. So I have a lot of medicinal herbs that we sell for salves, tinctures, whatever someone wants. And it's just now we've been here for 6 years, and I'm blessed. And then I get to meet people like you, right? And it's just forming a little community.
Yes. Well, thank you for sharing. Do you remember, I don't know if we should share this with the world, but do you remember right before COVID when it was like still in China, hadn't made its way to the US yet, and you and I were trying to record that reel of like, COVID's never going to come to the US. This is such a hoax. And every time we went to record, that drill would go off.
Oh, yeah, that's great.
That was just like the Lord like telling us not to post that because we were wrong. COVID did come to the U.S. But, well, thank you for sharing that. Will you share with us a little bit about, like, what is compounding pharmacy? I think there's so many people, when I tell them, go to a compounding pharmacist or get your progesterone from a compounding pharmacy, that's just is such a foreign concept, right? Not to go to CVS or Rite Aid. So can you give us an idea of the difference between compounding pharmacy and retail pharmacy or conventional pharmacy?
Yeah. So I'm going to just overall, retail pharmacy, we have access to commercially made medications, right? In conjunction with the FDA, and it's commercially made. Set amount of milligrams, set form, it is what it is. But we know in some cases, pet prescriptions, kids, hormones to a certain, degree, we want personalized medications. So that allows us, because it is not commercially available, to make a prescription to a certain standard because of whatever, going gluten-free or, certain dosages specifically for children. So it's a personalized approach.
Yes, and that's beautiful. And I think to add to that too, what I find with my clients, at least, is oftentimes when I'm sending them for compounding pharmacy, I'm sending them to avoid some of the ingredients that are in retail pharmaceuticals that we don't want them exposed to, right? Additives, food coloring. What are some of those not so great ingredients that we could avoid by using a compounding pharmacy?
So I think one that sits for your type of population is progesterone, right? So Prometrium is a commercially available form of progesterone, but it is in peanut oil. So a lot of people cannot tolerate the peanut oil for whatever reason. So that would give us grounds to compound in a different form, right? A different inactive form. And I should mention, just before we go on, I am set at the same standards as FDA. So what the FDA sets for manufacturers, right? I've got to fall in, and we test our products. I've got to fall in plus or minus 10%, the same as just what pharmaceutical manufacturing companies are set at. So we do have strict standards. It isn't just willy-nilly.
Right. You're still regulated, right? For safety, essentially. So let's talk a little bit about progesterone suppositories. That is something that I have repeated conversations with women about, is the use of progesterone suppositories. And in the holistic world, there's some apprehension to use a pharmaceutical in general, right? Which I totally understand. My perspective is that progesterone is probably one of the most benign pharmaceuticals that we could recommend or prescribe. And I would love to just talk a little bit more about that. So I have found in the fertility world that if OBs are willing to give progesterone, a lot of times it's oral or IM, so an injectable. I, however, much prefer a progesterone suppository. We're getting that progesterone right where we need it at the cervix and the uterus, as opposed to having, if we take something orally, it has to pass through the gut and the liver before it gets to the bloodstream. So we're not we're not so confident that it's getting right to the cervix and the uterus. So I'm often recommending ask your provider for 200 milligram progesterone suppositories. And I will tell them in quotations, ask your provider for this. This is all they have to do, right? 200 milligram progesterone suppositories, send it to the compounding pharmacy. And I'm always telling them, call your compounding pharmacy ahead of time, make sure that they have it, and then tell your provider exactly where to send it. And I find that that providers don't seem to even know that they can write a prescription like that. They seem like I have to coach my client to coach their doctor on how to write their prescription. Can you just talk a little bit about that? Like maybe some tips or tricks or ways that we can make this easier for people when they're trying to get these pharmaceuticals from their providers?
I think there's just a huge overall disconnect in, and forgive me for saying this, just OBGYNs, right? There's OBGYNs that know about hormones and how to prescribe them. But if they're just simply regularly delivering babies and that's it, they know no different. They have not been taught of different options, right? It doesn't exist. It's foreign. So you're exactly right. You've got to either find a practitioner that knows about bioidentical hormones and the compounding pharmacies. And then a tip about that is just call your local compounding pharmacy, right? Now, by the time they get to you, they probably already have a set OBGYN that they're working with. So it'd be kind of tough. But for the people who are just new to this and want to find a practitioner that is open to whatever, my suggestion is to call a compounding pharmacy and say, hey, who do you work with that is open to just XYZ? Because
that's
we kind of deal with the not normal physicians, right? So we kind of have a clue of who's more open. But it takes, what do I need to say? But you've got to coach them through it.
Yeah, that's a really great recommendation. And that's not something that I've thought to advise my clients to do before. But to reiterate what Hilary's saying is call the compounding pharmacy in your area and say, hey, what providers in this area do you see prescribing progesterone suppositories? And they'll give you their names, and then you can try to get an appointment with those providers. That's a really great recommendation. That's helpful. Wonderful. Let's talk a little bit about some of the pharmaceuticals or the drugs that we see being used frequently in the fertility space. Let's talk through the mechanism of action of how are these drugs working? Maybe what are some of the side effects or what are some of the nutrient deficiencies that we see coming from some of these fertility medications, namely Clomid, Letrozole, trigger shot. I'd love to dive into that with you.
Can I throw something back at you?
Yeah, please.
I think a lot of times, do you find that progesterone is being underused? To me, like any of those medications that we're going to talk about, progesterone that's like the shining star.
Yes, 100%. Absolutely. And so the client population that I am serving through the fertility formula is obviously a population of women that are struggling to conceive, right? But we know the research is clear that the most common cause for recurrent miscarriage is progesterone. And the problem is there's a time period where we need progesterone to obtain pregnancy, right? This is how I explain it. Estrogen lays down the bricks of the uterine lining, right? So the first half of your cycle, estrogen's dominant and it's coming through the uterus and it's laying bricks down. The second half of your cycle, the follicular phase, is where estrogen is dominant, the first half laying down the bricks. After ovulation, you move into the luteal phase, and that's where progesterone should be dominant, right? And progesterone is like putting mortar in the bricks. So now we have bricks and mortar making the uterine lining really strong, right? Or another way I explain it is like progesterone makes the uterine lining like topsoil. Without it, we have sand. We wouldn't want to plant a tree in sand, right? We can't implant into sand. We need to plant a tree into topsoil. So if we don't have the progesterone, we just don't have good enough uterine lining for implantation to even occur. And then following that, if implantation does occur and progesterone is not high enough, then we don't have adequate uterine lining or topsoil for the embryo to continue to grow. So in my experience working with hundreds, maybe thousands of couples at this point, is that when they get pregnant, the OB is not checking progesterone, most likely. So you call your OB and you're like, hey, I'm pregnant. And they say, congratulations, come and see us when you're 10 or 12 weeks and we'll do an ultrasound. Well, what about the first 12 weeks of baby's development? That's the most important part of baby's development is the first 12 weeks. And the conventional fertility model is completely overlooking or ignoring that part, right? And so what we do differently in our program is the minute that one of my clients says I'm pregnant, I'm on their HCG and their progesterone like as fast as I absolutely can be, right? And I'm looking for progesterone levels once pregnancy occurs to be over 23 at the lowest. And if they're not over 23, then I'm saying, hey, we need to get you on progesterone like ASAP. And if you don't already have a provider on board before you get pregnant that's willing to prescribe progesterone, then we're like in this panic-stricken situation that we don't want to be because we want to be excited. We're like finally pregnant, right? But now we're like a little fear-induced because we know we need progesterone to sustain pregnancy. So that was like a tangent to answer your question, Hilary. But yeah, progesterone is so underutilized. And kind of to like go back to what I had mentioned before with a lot of people, in my experience at least, being hesitant to use progesterone or because it's a pharmaceutical.
Progesterone is bioidentical, right?
Yeah.
So when we talk about hormones, the sphere that is given to us are because of the synthetic. It's the progestins. Progestins have their own side effect profile, it's another ball game. So when we talk about bioidentical hormones, it's the exact same hormones that our body's producing. Exactly.
Yes.
Right?
Exactly.
So to me,
yes.
when done properly, they're very, very safe. And if I had to pick out of all the bioidentical hormones, I always say I'll slather progesterone all over myself because I feel that it's so protective.
The reason people sometimes they'll want to increase their progesterone levels naturally. And I totally respect that and understand that. The thing is that it takes quite a long time to do that.
Yes.
So if we're in a situation where we want to conceive, it's going to take months and months and months and months. It's just not, you're not going to
you don't have that.
as fast as you
need it now.
Yes, exactly. Yes. And so we still want to do things, right? Like cortisol steals progesterone. So if you're super stressed, cortisol stealing progesterone. So we're going to support your adrenals and help your body to manage stress better. So you stop stealing progesterone to make cortisol. But still, it takes time. Like natural healing takes time. It just is what it is.
The reason why I asked about progesterone is before you get to the Clomid and the injections and everything else, progesterone does not have all these side effects. I mean, the potential of big side effects is not there. There's no drug nutrient depletion. So as we develop our conversation about these infertility medications, progesterone, as you just mentioned, is the foundation, but it's just so forgiving as well. So,
yeah, absolutely. Yes, I think those are all good points to highlight as we segue into the deeper conversation. So I'll let you take it away if you want to kind of dig into some of those pharmaceuticals and how they're working and things that we just need to be cautious of and watch out for.
I'm going to ask you, out of all the infertility medications other than progesterone, we love that stuff. What's the next most common for you that you see that's prescribed?
Clomid and Letrozole, maybe 50-50, but I would say the pretty standard procedure in the OB's office, in my experience and that of my clients, is we're not getting pregnant for a year. We have a good ultrasound within normal limits. We're not seeing anything. HCG is clear. HSG is clear. So we've flushed the fallopian tubes. There's no blockages. Let's give you Clomid. Let's induce ovulation and see if we can get you pregnant that way.
Okay. So we know that Clomid stimulates pituitary gland to release hormones. That's how that works. But the nutrient concerns that we see with the drug nutrient depletions, because I think that's key, because a lot of people, when we look at infertility as a whole, it's just they're not nutrient sound in the first place. If we add a medication in there that causes nutrient depletions, then we're kind of just compounding the whole problem. So typical nutrient concerns that we see with Clomid, vitamin B6 deficiencies, we'll see folate deficiencies, which, folate's huge in a pregnant population, and then zinc.
Mm-hmm. And B6 is huge for this population as well, because B6 is a cofactor in the production of progesterone. So if we're on Clomid, which is depleting B6, now we're hurting our progesterone also.
Yes.
Yeah.
And B6 is how, that's how we regulate hormones. It's got a huge involvement. B vitamins are so underutilized. It's crazy.
Right.
And not to mention, folate, and you need that.
Yeah, absolutely. And I think it's worth noting too, the way in which Clomid stimulates the pituitary is by blocking estrogen receptors, correct? So it blocks estrogen receptors. So essentially it tricks your brain into thinking that you don't have any estrogen. So it hypersends the FSH, the follicle stimulating hormone signal, to the ovaries. And that's what produces estrogen. So now on top of these nutrient deficiencies, you end up in a state of significant estrogen dominance. So your estrogen is even more unopposed. So you need even more progesterone. And we just kind of end up in this like domino effect, hamster wheel sort of situation here.
Right. And I mean, when we think about hormones in general and just specifically estrogen, I mean, there's 3 phases of detoxification. Your phase 1 that, takes the estrogen out of the fat, and that's more of the greens and cruciferous vegetables. But the other thing is this methylation piece, this phase 2, and B vitamins, all the B12, B6, and folate are that's what puts that into water so you can get rid of it. So yeah, it's huge in the hormone world.
Right. Yeah. So we're not only depleting the B vitamins, we're also interfering with detoxification from the body. Yeah, absolutely. What do you think about letrozole? Oh, go ahead.
Letrozole is like, that's the same type of thing. I did find some information. I was doing some digging because I'm an evidence-based girl, right? I love my studies. And I was looking at letrozole, and they put an interesting spin on it and saying that they notice that letrozole works better with vitamin D supplementation. But
that's interesting.
I was thinking, because you've always got to read in between the lines there, right? Is letrozole working? And this was in the polycystic ovarian syndrome population. Yeah. So is vitamin D actually potentiating and letting the drug work better? Probably not. It's probably increasing insulin sensitivity on the backside through vitamin D. And we know that your vitamin D has to be spot on for so many things, including pregnancy. So I'm not buying that letrozole needs vitamin D to work. It's just in that population base.
Right. And is it just the vitamin D itself? Is there evidence to show that vitamin D itself influences fertility, right? Which there obviously is. So yeah. Is it the synergistic effect, or is it just that they're also taking vitamin D?
Yeah.
Yeah, these are the questions that we're here to help everyone to ask, right? This is one of my goals in hosting this podcast, is to encourage you all to continue to ask questions and to critically think through situations like Hilary has demonstrated for us. Yeah.
Yes. It drives me nuts. It's like, yes, critically. Yeah.
Today's episode is brought to you by the Fertility Formula Masterclass. My team and I have helped hundreds of married couples conceive naturally without IUI or IVF. If you're struggling to get pregnant or stay pregnant and have been told there are no other options, don't stop searching. There is hope, and finding the root cause is key. If you want to learn more about how we can support you on your journey to motherhood, head over to drnicole.morris.com, and don't forget, Nicole has an H in it. All right, let's get back to the show. How do you feel about letrozole being an oncology drug also?
Letrozole works by blocking, in the backside of things, formation of estrogen, right? So it is not like a chemotherapeutic in an oncology sense, right? We're not like changing DNA, destroying DNA, cancer cells. It's what we're doing is blocking the estrogen receptor sensitivity and how that works, but we're also blocking the formation of estrogen. Right. So I always look at it as just as we were talking about the B vitamins and how we detoxify estrogen. You've got estrogen. You've got to mitigate the incoming estrogen and stop the incoming estrogen, and that the way that the receptors sense estrogen, but we also have to detoxify and get rid of it too. So it's twofold. So to me, letrozole in the big picture is not like a chemotherapy drug.
Sure. Yeah, I think that's important for us to talk about, because a lot of people know that it's a cancer, quote unquote, a cancer drug also, or used in the oncology space, and that, is cause for concern, rightfully so. Nutrient deficiencies, same between letrozole and Clomid?
I would say in general, yes. But there are marked concerns about oxidative stress support too. So there are some indications of more vitamin E and CoQ10 and things like that.
Will you explain oxidative stress?
How do you explain oxidative stress? So I would say any sort of condition that gives, how would you,
I just describe it as little bombs going off. That's
free radicals, right?
Explain it.
Yes,
yeah,
it's just
they're just little bombs going off in the body that are destroying cells. So this is really interesting to tie oxidative stress back to fertility, though, because if we're giving you letrozole because we want to force ovulation, but the letrozole is causing oxidative stress, we know that oxidative stress damages the egg quality. So again, we're back to the hamster on the wheel because we're giving you something to force you to ovulate, but the same thing that's forcing you to ovulate is damaging your egg quality. However, experts in the fertility space would say that it's increasing your egg quality because it's increasing estrogen. So again, it's back to the same thing that we just said a few minutes ago, of like you have to critically think through these things. And this is kind of the point, is to help you all to ask questions and critically think through some of this.
Well, it's the big picture. You've got to look at everything. It isn't simply about the end result. I mean, I think fertility, the end result is getting you pregnant, keeping it viable, and delivering a baby, right? It isn't about all the things, the brick and the mortar, like you're, using earlier.
Yeah. And I agree very much so in a conventional sense, right? And that's kind of why we're here serving clients in a different way, because so much of the underlying foundational health is really where fertility happens, is supporting the liver to detox some of these hormones that we're talking about in gut health and all the foundational stuff that we know. But beautiful. Let's talk a little bit about thyroid medications. Do you feel good about talking about that?
Well, I love it.
I knew you would. So another thing that I run into a lot with our clients in the fertility space, but just in general, is thyroid abnormalities. We also know that low thyroid function or hypothyroidism is also one of the most common causes of unexplained infertility or infertility in general. But I would just say, like, general population, I don't know the percentage of the population that has thyroid issues, but I don't know. I could be off, but I would guess maybe 20%. What do you think? Do you know?
Yeah. Mm-hmm.
Yeah.
Do you mean
20%.
clinical like TSH abnormalities, or not just optimal?
I would guess that there's 20% of at least Americans. Again, I don't have the data, so I could be off, but my gut tells me, based on my experience, 20% probably have lab-defined thyroid issues. And there's a whole nother probably 10% or maybe more that have thyroid issues that is overlooked by the conventional world.
And I'd even dare to say higher than that, but yes.
Yeah.
Mm-hmm.
Yeah. So I'm having conversations about thyroid medications with my clients often. Let's talk about root cause for thyroid for a minute. What do you see in your practice as some of the big red flag root causes for all this thyroid abnormality that we see?
And I'm just going to say simple thyroid abnormality. I'm just saying that your body has no ability to take that free T4 and convert it to free T3. So you're symptomatic. Conventional, you're looking good. Symptomatic, you've got something going on. But it's your body's inability to convert to that free T3. So common, right? It's just, I don't want to say it's almost too obvious, but it's almost too obvious. It's vitamin D deficiencies, right? It's your lack of ferritin or your iron storage. You maybe are not getting enough iodine in your diet. You may not be getting enough selenium, but the biggest key player is stress. It's that cortisol that steals it, right?
Cortisol is a thief, right?
Mm-hmm. Mm-hmm.
Cortisol is a thief. To give clarity, let me back up for just a second and explain kind of how the thyroid works. So TSH is the signal from the brain, the pituitary, to the thyroid gland, telling the thyroid to secrete thyroid hormone. And then out of the thyroid comes mostly T4 and a little bit of T3. So T4 means 4 iodine, T3 means 3 iodine, right? So out in the periphery, if your thyroid is making mostly T4, out in the periphery, out in your body, an iodine is taken off of T4 and then it becomes T3. And that's what makes it the active thyroid hormone that we need to use. So what Hilary's describing is the lack in conversion from T4 to T3. So TSH might look good, but the body isn't doing a good job of converting T4 to T3. And what are those reasons? So those reasons being vitamin D deficiency, iron deficiency, low ferritin, cortisol, all of those factors. And 100%, I agree, right? As a population, we are super nutrient deficient. I think another one worth mentioning is the chlorine and the fluoride. So chlorine and fluoride, because they're all halogens. They're in the same area of the periodic table as iodine, and they bind tighter to thyroid hormone than iodine does. So they displace thyroid hormone. And where are we getting these things from, right? We're getting them from our drinking water. There's fluoride in drinking water in the majority of inner cities where Americans live, right? So there's chlorine and fluoride in our drinking water. And so it just stresses the importance of filtering our water.
Environmental, right? I mean,
yeah,
even you could add, gluten sensitivities. You can go, the list goes on and on.
Yeah, absolutely. So for people with Hashimoto's, we know that avoiding gluten, if you have an autoimmune thyroid issue, is very helpful because of the molecular mimicry between the gliadin protein in the gluten mimicking thyroid hormones or thyroid cells. So that can be another root cause, right, as well. So digging into the thyroid is opening a whole can of worms, I would say. But to get us back on track to the medications, can you kind of walk us through, like, what are the different options for medications? I think this is another area where people really get confused between Armour and NP thyroid and compounded thyroid and Synthroid and Tyrosine and all the different things.
Mm-hmm. So foundationally, like the starting point is Synthroid, right? That's like the oldest out there. Synthroid is a brand name product that's made by one manufacturer. From that, we can have levothyroxine. Levothyroxine is your basically free T4. So you're giving your body a free T4 to shut down that TSH in a positive way. But levothyroxine is made by several different manufacturers. So you've got all different renditions of what we call inactive ingredients. So some may have corn in there. Some may have cellulose. Some may have gluten. So it's very hard in this type of population that you and I are dealing with. A lot of these people are so sensitive that these inactive ingredients can throw things off. Not to mention they have dyes and other things. Now, for a big percentage of the population, that's okay. But I like to really, when I dispense my thyroid medication or even order it from my wholesalers, I am really trying to keep a one brand, right? I don't want multiple brands because then I could, in the long run, change up people's thyroid labs. It's just, you want to keep everything steady.
Yeah.
Then just recently, in the last probably, 5-10 years, they have Tyrosine. Tyrosine is the exact same type of formula. It's levothyroxine, but Tyrosine comes in a capsule and it has 2 ingredients. And I think it's more of a glycerin based in levothyroxine. So it's a solution inside a capsule. They also have a Tyrosine solution, the liquid form that's good for the pediatric population, but that's the cleaner version yet. That's cleaner than Synthroid and levothyroxine. So that's free T4. Then there is free T3, liothyronine. That's the Cytomel. So that's another aspect. So when people can't convert that thyroid medication to free T3, sometimes we'll do liothyronine. Then there's a combination of Armour thyroid. So Armour thyroid is levothyroxine and liothyronine together. So you're free T4 and free T3. My personal opinion, I'll put this on there. Conventional medicine does not like Armour thyroid.
Why is that?
Pardon?
Why is that?
Because I don't think they don't understand it, right? They don't understand the conversion process. So it's just, you're dumping 2 things at once. And I don't think they know how to control that. What I find in my practice is the people that if they come to me and they need Armour thyroid to feel good, I know there's a huge cortisol and stress involvement because they're just not converting. So, my goal when I, work with my thyroid patients is I want you to get off Armour thyroid, to be honest with you, but I'm doing all the work behind the scenes. I'm cleaning up the adrenals. I'm, mitigating stress. I'm looking at vitamin D, and you finally can take hold of your own free T3 conversion. So you don't need to rely on that in Armour. We can convert it,
right,
or we can just rely on just levothyroxine. Does that make sense?
Yeah, absolutely. So what route do you recommend going for people when they conceive? What is the safest in pregnancy?
My opinion would be levothyroxine alone until someone works with someone such as yourself to kind of figure out all the other in-betweens, right?
Because T4 is what crosses the placenta, right?
Mm-hmm.
So we need T4. So if we're on a T3 only product, then we can't guarantee that we have the T4 necessary to cross the placenta. And
For
T4
sure.
is imperative for development of the brain of an infant. In terms of side effects, what side effects do you see from Levo?
I do not see any side effects from Levo alone. If there's side effects, it's because the levothyroxine is not being dosed properly, right? So if you need 50 micrograms and all of a sudden you get 75 micrograms and you don't technically need it according to blood work, you're going to get hyperthyroid symptoms. So I think it's more dosage based rather than just a causation of side effects.
And to help people understand, what is the difference between Levo and Synthroid?
So Synthroid is one brand, one particular manufacturer making it. So technically, the chemical name of that medication is levothyroxine. What makes it Synthroid is a branded name, proprietary branded name made by manufacturer X.
Sure.
But because the patent fell off of it, any generic manufacturer can now make levothyroxine.
And do you find a difference in the inactive ingredients, the extra ingredients that are in that product?
For sure. Yes. 100%.
And so people will react differently to the two different medication. I mean, same medication, but two different brands, I guess we can say, based on the inactive ingredients also, right?
Yes. According to the FDA, it'd be the exact same copy. Yeah. I mean, but it's the inactive ingredients that they downplay. Yeah. I have no problem with someone taking levothyroxine in the generic form, but just when you get that dispensed at the pharmacy, the best advice that I have is stay with that certain manufacturer, right? Don't change it up, because then you will change it up, because the absorption could theoretically make a difference.
Be different. Yeah, absolutely. And I think when we're monitoring thyroid, it's so important to have consistency. So consistency in the medication that you're taking, consistency in the supplements that you're taking, consistency in when you have your lab work done. So I like to check my clients' thyroid between day 1 and 3 of their cycle. And I like them to go early in the morning. And we're not taking thyroid medication in the morning before we go to have our thyroid labs drawn. I think that's a really important piece. And then again, staying with the same medication and the same supplements. So if you're taking supplements to support thyroid health, in 1 month that you're taking them and you have your labs drawn, and then the next month you aren't taking it and you have your labs drawn, it's not consistent in what you're doing. And that's going to influence your thyroid and your medication dose. And it's really important to have that consistency when you're trying to balance your thyroid.
It is that sensitive. Yes. I do want to add one other thing to that though. I typically recommend people stop their biotin and their B vitamins 5 days prior, right? Because that will influence how it's being processed in the lab. It's not going to influence what's going on in your body, but how the lab does their thing. It can change that.
What influence do you see biotin or the B vitamins have on TSH?
Nothing directly. I mean, B vitamins your body needs anyways, even in the thyroid sense, but it's a chemical reaction that at the lab itself causes that.
Mm-hmm. So how do you see it play out in labs though? Do you see an increase in TSH or a decrease in TSH?
Typically, I'll see an increase in TSH and I will potentially see higher antibodies.
Oh, I didn't know the antibody influence, but we make that same recommendation as well. We recommend 3 days, but now I'm going to change my recommendation to 5 if that's what you do. But we make the same recommendation with biotin. I think another piece of the puzzle that we really hadn't spoke about in terms of thyroid health is the thyroid antibodies, right? And that is something that we're screening for. And unfortunately, or fortunately, we find thyroid antibodies or Hashimoto's in so many of our clients who have normal, we'll say in quotations, TSH, free T3, free T4, but they have super high antibodies. And we know that thyroid antibodies correlate with infertility. So that is a huge oversight by the conventional OB model that is not looking at thyroid antibodies, or really typically not looking much further than TSH. So if you are listening and you say like, oh, my TSH is fine, my thyroid's good, like, no, you're just like scratching the tip of the surface of everything that we can look at underneath to address thyroid health. And so something that I'm often explaining to my clients is there's not really a pharmaceutical quote unquote treatment or intervention for elevated thyroid antibodies, right? We're not going to prescribe levo or synthroid because you have thyroid antibodies. So that comes down to like very much a root cause lifestyle environmental toxin approach is how do we shut that immune system down. Your immune system should not be attacking your thyroid. Your body's smart enough not to attack itself. So what's actually in the thyroid that your immune system is going after is what we need to get to the bottom of. So I think it's important. I just wanted to add that touch there, like that notion there that just because your TSH looks good doesn't mean you don't have thyroid issues. And if you have thyroid antibodies, it doesn't mean that you need levo or synthroid. You may need a different approach.
Mm-hmm. And I think it's exactly, that's what I was thinking. It's more environmental and lifestyle, if anything. And to me, thyroid antibodies, I use it as a predictor sense, right? So thyroid disease runs in my family. I'm checking my antibodies once a year. And as soon as I see them starting to increase, I'm like, whoa, what do I need to do? What do I need to change? So yes.
Absolutely.
100%.
And I think that brings us to the point too, which is so important to remember, is that genetics load the gun, environment pulls the trigger. So you have that genetic predisposition, right? As do I. I have a lot of thyroid disease in my family history as well, but I don't have thyroid issues. However, if I ate gluten and didn't maintain a healthy lifestyle, I feel pretty confident that I probably would, right? So we have the power to maintain a lifestyle so that our genetics are not always expressed, which is really an incredible power that we hold over our bodies, right? But so important. Very good. Well, thank you for sharing that. Super helpful. I'd love to just pick your brain about birth control a little bit as well. So birth control, I mean, I don't know what percentage of the population's on birth control either, but I could make my guess. I don't know. But we know it's everywhere, right? There's birth control in the water, in a lot of cities, it's everywhere. In birth control, I don't know, it's like kind of handed out like Skittles. So I'd love to just hear your perspective. I know you have a lot to say on birth control, but give us a little perspective in terms of how the pharmaceutical has an impact on our body, what nutrient deficiencies we're seeing with birth control, what organ systems it's influencing. I'd love to just kind of dive into that with you.
It is very disheartening that we've got all these options. You and I both know that there's so many options so let me back up. Why would someone be on birth control, right? To prevent pregnancy. There's obviously that, but the other thing is, and it's becoming earlier and earlier and earlier, is that these younger women have painful periods, right? Mm-hmm. Their periods are crazy. And the only way conventional medicine knows, and there's so much behind that we just like kind of talked about, is shutting off your own production of hormones.
Yeah.
That's what birth control is nowadays. That's kind of like forefront. So it's just you taking a synthetic hormone, progestins or estrogens that are synthetically modified, giving it to yourself, and it's signaling your ovaries to not produce any hormones, right? So you just shut off that response. But by doing so, you're still storing and you're still mitigating this whole estrogen dominance and, more of a progesterone deficiency. But as it comes to play, birth control is notorious for depleting B vitamins, B6 and folate again. So we just talked about, we might be heavily bleeding and creating this estrogen dominance response because we have too much estrogen stored in our tissues. We're shutting that off by giving birth control, but we still have this estrogen dominance problem. We have now shut off our ability to even detoxify this estrogen. So it's a compounded problem. It's just not root cause. Meanwhile, if we know that birth control, if you take it for years, you're more, there's so many different potential ramifications of that in the long run, leaky gut. There's hormone, infertility, I guess, in the long run or later down the road. It's not a healthy situation, and it makes me sad that these younger women are not given any other options or told about that. It's like informed decision making. There's nothing.
Yeah. And ultimately, the reasons that I see women be put on birth control is similar to the list that you gave, right? But it's acne, irregular periods, heavy, painful periods. And so essentially what is happening when birth control is being prescribed is that, like you said, the hormones are being suppressed. It's a suppressive mechanism. And oftentimes women will think like, oh, well, I still have a period. No, you don't actually have a period. You're bleeding, but your body is not naturally cycling its hormones. You're only bleeding because of the withdrawal of progesterone during the certain pills, during the birth control, right? Where there's actually no hormone being distributed. So you're not actually having a period. You're just bleeding, right? And there's a difference there with how your hormones work in the brain. And we need that to work. So in that suppressive state from those synthetic hormones, we're essentially kind of putting the body back into puberty or maybe menopause, right? We're just like shutting that system down. And so we also know that birth control changes pheromones. And there's research that shows that women that marry on birth control have a higher divorce rate than those that don't, because the way it changes our pheromones, right? Like it sounds like a silly little study, but it's true. And our pheromones are chemical signals between women and men that help us feel attraction to each other and communication, right? So the ramifications are certainly there long term. And I can't tell you the amount of couples that we serve in our program where women were on birth control for 10 years, or maybe some women were on birth control for 3 months or 6 months. And it still has an impact on their hormones. And we have to ask ourselves, if we're taking birth control, which is depleting B vitamins, and now we can't detox, we have all this buildup of synthetic hormones in our body. And what is the long-term ramification of all of these synthetic hormones in our body? How does that predispose us for cancer and in other pathology later on down the line?
Well, I think, when people want to come off birth control, it's a no-brainer that you've got 9 to 12 months at least of cleanup to even, go to step 2. I mean, you've got to detoxify yourself off birth control to clean up off of, and your body's got to figure out what it needs to do. And it's tricky. And again, that's not being told. So here's your birth control at 16 and for whatever reason. And then when you're ready to get pregnant. So let me ask you this. If someone gets put on birth control, let's just say at 16, and they are looking to get pregnant at, let's just say 25. I know that it's going to take a while for their body to relearn normal hormone production. So let's just say that's 12 months. Now, clinically, conventionally, a woman has to be trying to conceive for 12 months before she's deemed infertile. So do you find that conventional medicine are slipping these women into fertility treatment plans too soon?
Yeah, that's an incredible question, and truthfully not something that I've actually thought through before, but I would just initially say yes, absolutely. Because I agree, it takes a solid 9 to 12 months for the body to regulate. Even if you come off of birth control and your cycle starts again right away, it doesn't mean that you're healthy, right? We have so much work to do. We need to improve egg quality. We need to flush out the liver. We need to get, birth control is the most potent xenoestrogen. A xenoestrogen is a chemical compound that is meant to mimic estrogen in the body. It is built to be the most potent xenoestrogen. And we know xenoestrogens cause infertility. If that's a new term for you, it's XENO. And think of it as like fragrance and plastic and these environmental toxins that are hurting our fertility. And again, it's the most potent one. So it's going to take us months to detox the body from that. And truthfully, you don't personally, I would say want to conceive and get pregnant while you are loaded on xenoestrogens. That is going to have a long-term effect even on the fetus. So I think that that's such a valid point that you make, Hilary, is that yes, like maybe these women are not given realistic expectations. Well, we know they're not, right? That when you come off birth control, you can expect, a 12-month cleanup period, if you will. But you're right. They come off birth control. They're trying for a year. They get to that 1-year mark, and then they're put into the infertility space where, reproductive endocrinology is now putting them on Clomid. So we're like just coming off a year of our cleanup phase of, it's just, again, it's like that polypharmacy, right? Maybe not all at the same time, but just one thing after another. So we're coming off birth control, we have our year, and then we're going on Clomid. And so there's another provider who I saw recently just talking about like letting people ovulate. And I was like, yes, it is a conventional fertility model. They are not letting women ovulate. And because birth control oftentimes will interfere with ovulation as well, right? So, I think that you make a really valid point, and that's something that I'm going to have to think on a little bit more and consider a little bit more deeply. But yes, absolutely.
And I think as time goes on, the more toxic we become in our environments, becoming more and more toxic, this is just going to be an ongoing issue. And I don't see it getting better in that picture.
Yeah, I agree. And I think the thing is too, that we can clean up the system from oral contraception, I think, faster than 9 to 12 months if you're well supported. If you have a provider that's walking you through the detox and cleaning up your liver, and you're doing skin brushing and castor oil packs and liver herbs. And I'm a huge fan of homeopathy, so I'm going to do homeopathic biotherapeutic drainage, and I think it works like magic. So it doesn't have to be that. If you're listening to this and you're on birth control and you're starting to feel panic, like it doesn't have to define you, right? And it doesn't have to define that it's going to take you 12 months to clean up your system. But I think it just highlights the importance of getting support from a provider that can walk you through doing that safely and efficiently.
Yes.
Yeah. Absolutely. Well, thank you so much for sharing with us today, Hilary. I think we hit a lot of topics that will be of interest to a lot of the women that both of us serve. So it was really lovely chatting with you. Is there anything else that you'd love to share before we kind of wrap up our conversation for today?
I don't think so. I think it's just be your own advocate. Push, push, push. That's all. No one's going to save you but yourself, and just finding your community. So.
That's a great, solid piece of advice. And what about access to compounding pharmacies? Do you think that most people have access to a compounding pharmacy?
Yes. Yes. And if you don't, we've got several in our states. Just call around. We all know each other, right? If you are in a rural area and you don't have access, a lot of the compounding pharmacies will ship within the states too. So access it's good. You just have to call around
And pharmaceuticals aren't our go-to, right? I would say the same is probably for you as well, even being a pharmacist. Pharmaceuticals are not our go-to, but sometimes they have a place, right? There's a time and a place for the different modalities that we have to use. Pharmaceuticals are way up on my list, right? There's a lot of things I'd like to do with my clients before we get there, but sometimes they bridge the gap for us and they help us get where we want to go a little bit faster, right? When we want to get pregnant, we want to usually get pregnant like 6 months ago. So using a little progesterone or a little thyroid hormone to help that happen in 2 months versus another 12 or 18 months, to me, it's worth it. But ultimately, at the end of the day, that's up to the client and what feels right for them, right?
Mm-hmm.
Wonderful.
I call them lifeboats. We don't have to use our lifeboats all the time. It's a quick transition, right? And then you can be done.
Absolutely. Wonderful. Well, thank you again for sharing with us. How can people find you if they would like to learn more from you?
So we are at Apothecary Co. downtown Oxford, Michigan. Our website probably is best, apothecaryandcompany.com. We're on Facebook. We're on Instagram.
Wonderful. Well, thanks again. We'll chat soon.
Thanks.
Yeah. Thanks for hanging out with me on today's episode of Prescribing the Truth. If you loved our chat, you can find me on all the socials. Come say hi on Instagram at dr.Nichole Morris. And don't forget, I drop exclusive content on YouTube every week, so be sure to subscribe so you don't miss out. Also, I've got to tell you, if you are in need of high-quality, research-backed supplements, check out shopdrmorris.com for my full line of third-party tested, USA-made products. My Prenatal Plus is top of the line for fertility support, and if you've got little ones, grab a bottle of Kids Complete too. Lastly, if you and your husband are trying to conceive naturally without IUI or IVF, my team and I would love to support you, pray with you, and walk this journey with you. Just head over to drnicholemorris.com, that's Dr. Nichole Morris, Nichole with an H, to book a preconception consultation with me. Thanks for joining me today. Stay informed and God bless.